Next slide, please. Next slide. Can you hear me? Yeah.
Yes.
Okay, this is just about talking about the common fungal infections. We have superficial and deep. Some of these things have been said, so I'll just skip them as I go along. Can I have the next slide? Next slide, please. Okay, still on superficial infections, the ones we have. Tinea is very common. Next slide, please. Next slide, okay. So we have the deep mycosis, which we have candidemia, cryptococcus, they talk about that a lot, histoplasmosis, aspergillosis, and PJP. Go on, please. Next slide, please. Okay, so what are the risks for fungal infection in children? Usually in Africa, we have a lot of malnutrition. Then Nigeria has the second highest population of HIV in children globally, and it's about first in Africa. And only 35% of these are actually on ART. So we expect a lot of patients with fungal infection in Nigeria, especially patients who are HIV positive. Then, of course, we have a growing number of patients with cancers now, and also nephrotic syndrome. Can I have the next slide? Okay, also, it's been found that low socioeconomic status, poor hygiene, and overcrowding has been linked to fungal infection in children. Go on, please. Next slide, please. So this is just about the epidemiology, that to show that fungal infection is very, very common. About 250,000 cryptococcal meningitis has been found in HIV patients. Also, close to 1 million invasive candidiasis, half a million pneumocystic duroventral pneumonia, and 250,000 invasive aspergillosis. So this is very, very common in patients globally. So we need to look out for them. Next slide, please. Okay, so studies have been done, and they found out that the prevalence of oral candidiasis is variable from America to Chilean children, from 2 to about 3% to 88%. And also is very high in African children, and also children in Chile and in the Hindu population. And that fungal infection in children is actually commoner than we think. Next slide, please. Okay, so Oladele et al. And then it also found that more than 20% of school-age children have fungal infection, tinea capitis, and this translates to close to 15 million children, which is a huge, huge number. Go on, please. So there's this interesting study by Jabra Ricks et al. In 2001, where he compared data from Nigerian children who were malnourished and children in the United States who were HIV positive, and he found out that fungal infection was actually even commoner in the Nigerian group compared to the HIV infected and the non-HIV infected children in US. And that the interesting thing was that he found other species that were not commonly recovered from the found in the Nigerian children. Which next slide. Next slide, please. So in Nigeria, it's been estimated that 75,000 patients with HIV/AIDS would develop pneumocystic carrier pneumonia, and if you extrapolate this, it goes to about 40% of rates in children, which is very, very high, very, very high. So and that with this growing number of patients who are presenting with advanced HIV disease, which we are seeing commonly now, then with advanced HIV disease and adult local advanced fungal. Next slide. Hello. Okay, now I'll be looking at the gaps, which is our main focus for today. And there's gap in knowledge, there's gap in index of suspicion, of course. Then there's gap in laboratory diagnosis, which has been talked about. There's gap in research, cost of care, and poor surveillance. Next slide. In terms of knowledge, a study that was done by Oladele et al. Again also found that the knowledge of specific fungal infection was very, very low. The general knowledge was high, but a lot of younger colleagues have never even managed a patient with invasive fungal infection before. So knowledge is relative to the level of training. That's what was found out in that study. Next slide, please. Also, in terms of poor, because this knowledge is not very adequate. A lot of times we don't make a diagnosis of fungal infection until we look for bacterial infection and we don't find, and somebody say, oh, can this be fungal? And then we start looking. And usually then it's usually too late. So we should think about fungal infections early, and we can save the life of our children, especially in children. A lot of times we don't even think about fungal infections first. We do all manner of things, then we'll come later, oh, it can be fungi. For a patient who has gone from one hospital to the other all over the town and coming to you after 1 week, we should think about fungi. We have a lot of HIV patients, think about fungi. Malnourished children, think about fungi. So we need to think about fungi early, because early diagnosis will lead to early treatment. So, so in South Africa, in terms of laboratory diagnosis, South Africa is the only country, African country with a national mycology reference lab. We need to have that. We need to have more of that all over Africa. We need to have people that can, with more resources for diagnosing fungal infections. We need to have more trained personnel. We need to have point of care and near point of care for diagnostic tests, which is rapid. If you can make a diagnosis early, we can treat patients early and it can get better. Next slide. So, I got this from another publication from Oladele and then in that. To have accurate diagnosis, we require immunofluorescent microscopy, and none of this is actually available in Nigeria currently. So those are areas that we are lacking. We can't do more extensive tests. Talk about cost of care. Cost of care. So antifungal drugs are expensive for patients to buy. The expensive ones are not easily affordable. So we need more companies that can produce cheaper and quality effective antifungal medications for these children. Next slide. Next slide, please. So HIV, ART. So the 95 goal, which is the Vision 2030. For us to achieve this, we must commence all HIV positive children on ART, because we can't achieve this without doing that. Next slide. So lack of surveillance, no lack of interest. People are not interested in fungal. They don't even think it's there, no data. So we're having a lot of issues. So the number of pediatric fungal infections usually are not known. Poor or lack of surveillance. Next slide. So we are not looking. This is just a map showing countries that have data and those who have publications and those who have abstracts. You can see that Nigeria is in between. A lot of countries don't even have any data at all. Next slide. So research. Look at publication. We have very little publication of fungal infection in children. In the last 44 years, just 20 from Nigeria. And well, there are quite a number of publications in adults, so we need to work more on children. Next slide. So again, we have a lot of that very low data from Nigeria, in children especially. So we still say the same thing, especially in common fungal infection in children. We are not looking out for, we are not doing a lot of publication. So we find very little studies coming out from Nigeria. So we need to do a lot more studies to create more awareness. So this is just, I got this from another publication where we looked at this. I think we can skip this slide. This is, so next slide, we can see, look at this table, look at different fungal infections. You see a lot of question marks. These are the questions we need to ask ourselves, we need to ask. And this is a general one. So if you talk about children, we have very little to do very little information in pediatrics. So we need a lot of information. Information is going to help us a lot. Next slide, please. I've talked about this slide. The question marks are what we need to answer. So, in all the statistics we've been getting, how many of these are children? Children, how many of them are children? We need to work on children. We need to look at children and know what is happening. Now, for pediatrics recently, there was a study from Nigeria on candidemia in neonates. Baizenwa et al. 2017. There's one study from Calabar. Oladile et al. Has been doing a lot on histoplasmosis. There's a study from Mycology which says that they couldn't find cryptococca in there, but there's a geographic variation because in Sokoto they actually solve cryptococca. So this can be variable depending on what location you find yourself. So for the fact they didn't see in Mycology doesn't mean it's not happening elsewhere, because we are seeing in other centers. Then it looked like I said earlier, they had also one case in ICU, and we also had a child recently that also had cryptococcal meningitis. So these are too few. We need more work. We need more data. We need more information. And of course, the stigma of HIV prevents parents from bringing their children to the hospital. So we need more work, like I said, more on pneumocystis jirovecii pneumonia, more on aspergillosis, cryptococcal, histoplasmosis. There has been a lot of gap in histoplasmosis, so we need more work to be done. And how can we do this? Awareness. We need to create more awareness, like what we are doing now during this conference. We are creating a lot of awareness. People are getting more aware. Doctors think that cryptococca doesn't. Just that we are conferences like this is going to help us create more awareness. Then as clinicians and health workers, we need to create more awareness, advocacy, talk about it, and let people be aware that they need to look out for fungal infection in children, and that will actually reduce morbidity and mortality for us. Thank you. Hello.
Hello. Hello.
Yeah.
Yeah, Dr. Akintan.